Good afternoon, everyone. My name is Mariah, and I'm with the University of Arizona Center for Rural Health. Welcome to the webinar series. While we have people joining, we would like to take a minute to express our gratitude to our partners, the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Next slide. Some notes for this webinar. The audience will be muted throughout the webinar, but we really encourage you to enter questions throughout the chat box or throughout the presentation in the chat box. At the end of the webinar, a survey will pop up in your web browser. We'd really appreciate you taking a moment to complete the survey. It helps us to continue to improve with your feedback. And lastly, a recording to the webinar will be posted after conclusion. Next slide. Today, we are really excited to hear from Dr. Pogriba Brown, who is an associate professor of epidemiology at the Zuckerman College of Public Health. And with that, I will turn it over.
All right, thank you, Mariah. So thank you, everyone, for joining the webinar today. And I'm excited to be able to talk to you about the study that we're working on and maybe get some ideas from you all about ways that we can expand and collaborate a little bit more, especially in the rural parts of the state. So I'm going to jump right in. So I'm an infectious disease epidemiologist. I'm at the Department of Epidemiology and Biostatistics in the College of Public Health. And starting with the land acknowledgement, the University of Arizona sits on the original homelands of indigenous peoples who have stewarded this land since time immemorial. Aligning with the university's core value of a diverse and inclusive community, it is an institutional responsibility to recognize and acknowledge the people, culture, and history that make up the Wildcat community. At the institutional level, it is important to be proactive in broadening awareness throughout campus to ensure our students feel represented and valued. So I'm going to unfortunately take you back a couple of years through the pandemic. But for those of you who have been in Arizona throughout the pandemic, you know that we were hit particularly hard and had at one point, actually at 2 points, had some of the highest transmission rates in the world. So this is a screenshot pulled yesterday, actually, from the dashboard from the Arizona Department of Health Services. And it shows the number of cases that we have had over time. Many of you probably visited the old dashboard and were tracking things on for those of us who are in public health and epidemiology, daily basis, and then weekly. And now that things have slowed down a bit, cases are reported every week and they're updated. So it's just showing you the trends that we had over time and the people that have been impacted, and differences between those different groups. So you can see where all of the different kind of spikes that we had over time in kind of mid-2020, and then over the winter months of 2021 and then 2022. And I will try to kind of keep an eye on the chat. If a question comes up intermittently, I will be happy to try to answer it. If not, we'll answer questions at the end. Let's see. So as of today in Arizona, we've had over 2.5 million cases reported to the state health department. This is an all but guaranteed to be a highly underreported number because it only counts cases that were tested in the laboratory. So those of you, myself included, who have used any sort of COVID home testing in the last couple of years, more than likely, most people did not end up reporting those to the health department. You can. Some health departments are accepting those results, but by and large, people don't. They hopefully look up the requirements or call their doctor to get a prescription and don't ever get counted officially in the numbers for public health surveillance. It also, of course, includes people who were sick and never tested. We have that throughout the pandemic. So for vaccination, we have about 77% of the people have been reported to be vaccinated in the state. It's unclear if that is the number of vaccines or whether people are up to date. We do have a lot of differences across the state. So, for instance, Pima County is reporting 85%, and Mojave County is reporting 47%. I will say take some of those numbers with a little grain of salt, because it still says that Santa Cruz is reporting 185% of their population is vaccinated. So there's probably a little bit of data cleaning that still needs to happen there. Vaccinations are still pretty low for children under the age of 20, but are much higher with increasing age, which is good news. And the latest booster that has been recommended has been a very low uptake, and we're starting to see susceptibility increase over time. So that's just, I want to just kind of give people an overview of where we are right now. But in thinking about where we started with the pandemic, a recent analysis in the Lancet showed that Arizona had the highest adjusted death rate in the US. So we had 581 deaths per 100,000 people, compared to Hawaii, which is admittedly an island, but at 147, or New Hampshire, which was 215. We were on par with some of the other countries that were the hardest hit. And according to that report, states with higher levels of poverty, less access to healthcare, and lower levels of interpersonal trust have higher rates of mortality. And states with high vaccination rates also linked to fewer deaths, which is a fairly obvious result. So I'm going to talk to you about the Arizona CoVHORT study, which is a collaboration between faculty at the University of Arizona. We also have a faculty member at ASU who has been working on this from the very beginning. And we have been trying to get this study up and running so that we could have a better idea of COVID in our state. So in early 2020, a lot of the epidemiologists were starting to really become worried and start thinking about this new emerging infection that was coming out of China. As early as March of 2020, my team actually started working with the Pima County Health Department to help conduct surveillance interviews for people who had these very early people, looked like that they had tested positive for COVID or looked like they might have COVID. And then that very next month, the public health faculty started to come together and start planning this CoVHORT study. And in reality, we really weren't sure what we would expect, but we know that given the novel nature of the pathogen and the situation, that it was important to be collecting data as real time as possible. We were awarded a seed grant from the U of A Bio 5 to start initiating things. And on May 28th, 2020, the CoVHORT launched our first online surveys. And I think that's really important for two reasons. One, we were one of the first studies in the state and really in the country to start collecting data this early. And also, as you'll see, many of the early studies that were focused on COVID were very focused on people who were hospitalized, because it was very important to understand why people are hospitalized, why people were dying, you know, the nature of that. But because of the way our study was set up, we actually were able to capture far more information from people who had mild and moderate illness, which makes up the vast majority of people who did and continued to get COVID. So that was important. So our overall mission was to determine the impacts of COVID-19 in Arizona communities and work in a way that recognized disparities and find ways to work with communities to collect data. We wanted to answer questions about, again, this emerging disease, who is likely to contract the disease and why, who is likely to get severely ill and what can be done to mitigate the impacts of that disease. And then really create an infrastructure for a wider group of researchers to collaborate. We know a lot of people would be interested in this, and we figured it would be less onus on the patients and the participants if we all came together on the back end and figured out what questions were important to us as researchers, and then present it with one survey rather than trying to enroll people into 20 different studies. And then work with local agencies to collaborate on research questions and dissemination of findings. So again, all of this was very early on, and our thoughts was we were just thinking about the immediate impacts of COVID, but that started to change over time. So, our goal was to have a cohort of 10,000 participants, and that was kind of a pie in the sky number when we first started, but as you'll see, we're actually getting pretty close to that. And as our study evolved, we started thinking about, we wanted to know what risk factors and comorbidities impacted the severity of COVID-19. And we had put something very general into our initial primary objectives, which were to identify any post-infection chronic health conditions. So I'm an infectious disease epidemiologist, but some of my other colleagues on this study are chronic disease epidemiologists, and we didn't know that there could be or that there would be long-term impacts of COVID, but we all have worked with either infections or chronic conditions that had a chronic outcome. And so, for instance, my work before this looked at things such as irritable bowel syndrome and having a history of a foodborne infection, where there's very, strong evidence right now that, for instance, Epstein-Barr virus causes MS, and so, or is a contributing factor. And so we were starting to think in that realm, but this was even before long COVID was known to be even a possibility. But as we started to learn more about that, we recognized that it would be very important to examine the relationship of things like disease severity with long COVID and what might be done to mitigate that, and also see what role things like vaccines and vaccine hesitancy had on the progression of the pandemic, and also people's both acute and long-term health outcomes. And so that really became where the study was starting to evolve to, and really where we are today is a bigger focus on those things, because we know that we've addressed many of the issues associated with acute infection, and while those are still very important, and we still want to do what we can to mitigate that, there are far more people who are surviving COVID and potentially having the possibility of developing long COVID, which could have debilitating effects long term, and for many people, we're seeing that. So we have recruited people in many different ways. This is just an example of 3 of them. So we have really strong partnerships with the state health department and many of the county health departments across the state. And so we don't directly recruit with them, but what we simply do is at the end of a case investigation, so if somebody gets sick with COVID and they follow up with the interview that is standard, at the end, they simply say, are you interested in learning more about a study? If the person says yes, then we send them an email with information, and then they can sign up for the study on their own. We've had a few partner studies where we share information back and forth to be able to allow people, again, just providing people information. And then initially we sent postcards and flyers because it was important for us to recruit both cases and non-cases, and I'll get into that in a little bit. And so we did that early on, and then the latest stage that we have been working with is starting to recruit in clinical facilities. So we have clinics that we are working with to be able to just put up flyers and share information about the study with people so that we can get that information as broadly disseminated as possible. So I mentioned the online surveys, and so if a person enrolls in the study and then provides both consent and then fills out a baseline survey, then there are what we call on-cycle surveys are going to be every 3 months. And then if they are reporting symptoms, then they get symptom surveys in between that time period every 6 weeks. So what we wanted to do is make sure that we could capture people who both came to us having an illness and not having an illness, and how do we deal with people who got sick if they were in the middle of the study? Because this is a longitudinal study. We have been collecting data for over 3 years now, and we knew that just because somebody came to us as a control didn't necessarily mean they would stay that way. They may become a case later. So when a case or a person reports that they have become infected, then they get a different set of questions, and then they continue to get those questions every 6 weeks. But we also didn't want to continue asking people questions every 6 weeks if they felt fine. So once you tell us that you haven't had symptoms for 2 surveys in a row, then we put you back on the every 3-month surveys. And there are some questions that are repeated every time, and then some that are maybe asked once a year or even just once ever in the survey. So the type of questions we ask cover kind of 3 major areas. So we have kind of questions about the infection itself, questions about your health, and then questions about your more general well-being. And so obviously if somebody becomes infected, we want to know things like if you tested positive, how sick were you, what your symptoms were, your duration of illness. And the symptoms are important because, and severity for long COVID, and we'll get into this, but how people's acute infection looks can drive whether or not they develop long COVID and how often that, and how quickly they can recover. We ask other questions related to health, such as age and chronic health conditions, a few other things related to reproductive health, because we have a faculty member whose expertise is in that area, and then just general well-being, social behaviors, stress, physical activity, etc. And you can see why it was important for us to talk to people who both, and still is, who both have COVID recently and have not, because, for instance, if I asked most people here if they were stressed out in the middle of 2020, then most people probably would have said yes, and that was irrespective of whether or not they were actually infected. And so it's important that we're talking to people who are both infected and not, so that we can kind of understand the difference between what some of these health impacts were based on simply living through a pandemic compared to what are the health impacts specifically related to the infection during the pandemic. So we, and actually we really want to go back really quick. One thing is we have this primary core study, but we also have some ancillary studies, and I'm going to get into those. But one of the things that's important to know about the ancillary studies is that we allow people to choose to participate in that if it's applicable to you and your circumstances. So we don't just share information with people or with other studies. We allow people, they only can opt in, and that'll become important here. And so I think just for people to be thinking about this, it is an online survey, but we have all data is protected. It's a HIPAA compliant protector. We've followed, we've gone through all of the IRB protections. And again, people are only opted into things if they want to participate. Let's see. So currently we have 8,925 people who have completed our baseline questionnaire. And about just over half of them have reported testing positive at some point in their participation. And we've also had people who have tested negative. And that's really important to us. And the reason we were able to get that information is because of our partnership with ASU. So ASU early on started, if somebody was going to the ASU site, which they had testing sites all over the state, and they signed up to get tested, you could choose to learn more about the study. And if you ended up enrolling in the study, then you, even because a lot of people were testing and maybe they tested negative, maybe they had to test for work once a week, and so they were testing on a regular basis. So it was good to learn about people who had tested negative because we wanted to know just as much about the people who weren't sick as those who were. And so again, we've had this continued participation over time. Obviously, somebody who signs up for our study, last month isn't ready for their 6-month survey. So these are a progression over time. It's a little bit of a moving target. But we've been thrilled to see the number of participants that have really stayed with our study for a very long time. And so we have over 3,000 people who have completed their 1 year, and over 2,000 for their 2-year, and just over, I think it's a little over 600 now who've done their 3-year. So this is our current enrollment. Average age is 47. We have an age range of 12 to 85. We did just recently add 12 to 17-year-olds, so the numbers on that are far lower, and I'll explain that. It's through a collaboration with CDC. More than half are female, which is typical in these types of studies, but we are working to increase that number. We would also like to increase the number of people who are Hispanic, to have better representation that reflects the state demographic. Right now it's about 14%. We also have about 85% of people who've had at least 1 dose of their vaccine, which is higher than the state on average. And that's not really surprising. Anybody who is interested in participating in a COVID study are probably going to just have a little bit different relationship with healthcare in general. And so it's a little higher. But one of the things that really surprised us when we first started looking at our data is the number of people who reported potentially having long COVID. And so the one thing, and I'm going to get into, the one really challenging thing with studying long COVID is that we don't have a great standard definition. So right now, the definition that CDC and NIH uses is people who report having 1 or more ongoing or new symptoms at 28 days post-infection. And so because we track people's symptoms every 6 weeks, we're able to track that really accurately. But, you're also looking at lots of different data, and somebody could, they could have gotten a secondary cold, or they could have done other things. So what we've now started to do is add in other questions. We directly ask people if we think that those symptoms are related to their COVID or if this is something else. But we still have had a lot of people in that general realm, and even over 1,000 people who at 90 days of follow-up or 3 months are still reporting some sort of symptom. So there is something going on, and I have been working with people kind of in the long COVID community, and this is a real disease. This is a real condition that people have, and there are a lot of people whose lives have been changed dramatically by it. We really need to do more to see what we can do to help people and go from there. So I had my team put this map together for this talk, actually, so that we could get an idea of where cases were distributed. And it's not particularly surprising, right? We'll have the highest numbers in Pima and Maricopa. Pima mostly because we focused our initial recruitment efforts here, and then we're able to recruit throughout the rest of the state. But other than Greenlee, so I would love to get some participants in Greenlee, and La Paz, which is, 2, we do have at least some representation across the state. But I do think that it's important, and that's one of the key reasons why I'm here today, is that we have better representation in our rural counties, and for people who are potentially struggling with this disease, to learn more about what their access to care is, what kinds of symptoms and other things they're having, so that we can help everyone across the state equally. So one of the things that has developed from this study is that because we had this cohort and we're continuing to go, we had a cohort and we basically started it with that pilot grant that I mentioned, and a lot of volunteer time, frankly, from faculty and staff and students to get this up and running, because we didn't have any funding initially to support really anyone. We were all just kind of trying to do this because we thought it was important. And then, so in September of 2022, we were awarded a grant from the CDC to conduct active surveillance for long COVID. So we, because we already had all of these systems in place, CDC really wanted to work with us to be able to do both passive and active surveillance. So the passive surveillance side is led by Dr. Jennifer Andrews in the College of Medicine, and that works with EHR data. We have ADHS is a large part of this grant, and at participating clinics across the state that uses MedSys data and other types of more passive data that comes in. And then the cohort study is working on the active surveillance side. So new cases that are coming in, and CDC really wanted to focus for this surveillance project only on people who were newly infected in the last 3 months, are then going to get followed for 18 months. So we're essentially just embedding them within CoVHORT and following them to see how that happens. So you could be somebody who is completely new to our study, and you recently got infected, you joined the study, and you're going to get the questions that CDC is interested in addition to some of our original questions. Or you could be somebody who has been part of our cohort study for a very long time. And let's say you get newly infected, you tell us, your every 3 month survey comes up and you tell us, yep, I was infected a month ago. You would also get those questions that CDC is focused on, in addition to some of the ones you would already get. And we're going to track that person again over time for the next 18 months. So all Arizonans are still being recruited into the cohort, and a lot of our question themes have remained the same, but we've changed it so some of our follow-up questions so that they are in line with the other sites across the country that are asking these questions. So some of the other ancillary studies that we're working on, so they're not quite as embedded within cohort, and some are not embedded at all. So there is the RECOVER study, which you may have heard of. It's a huge NIH study on more the biological mechanisms of long COVID. So one thing about our study is we are not collecting any biospecimens. We would have loved to be able to collect biospecimens early on, but again, without funding, that's kind of difficult. But RECOVER is a very clinical study, and puts patients through a gamut of different tiered medical follow-up exams. And that's led by Dr. Nikolic here at the University of Arizona. And I'm part of that study to a very small degree, but work with them on that. We've had a reproductive sub-study led by Dr. Leslie Farland, looking at both impacts to, we're looking at impacts to fertility, menstruation, and childbearing throughout the pandemic. We had another study called PANGS that was a grief sub-study led by Dr. Mary Frances O'Connor, who is one of the leading experts in the world on grief and the kind of both the physical and mental effects of grief. And then another study that I am leading, which is an RL1 with NIH, looking at the gastrointestinal outcomes of COVID-19, which are actually looking to be far more than we would have anticipated. So some of the, we've published about a dozen papers out of this study so far. And so some of them are things like, the design, symptoms, other things that we saw early on. But the last 4 studies are the ones that are the most focused on long COVID. So we, the first study that we looked at data early in, was 2020, 2021. And some of the results that we saw there, and I'll share a little bit of those. And then the next one was looking at changes in menstrual cycle, which is kind of for some people would be considered part of their post-COVID condition, the persisting GI symptoms. And then the one that I'm going to talk about probably the most today is how pre-existing conditions are associated with long COVID. So taking kind of a step back, I came to this talk kind of assuming that people knew what long COVID is, but I wanted to make sure that everybody was really on the same page. So the first thing is that not only do we not have a standard case definition, we don't even have a standard name. So long COVID is actually the term that was coined by patients. So patient advocates very early on were the ones that pushed this forward. So they started online support groups, and they even started online studies where they could start comparing people over time. And the original term was the long haulers, and that was coined by Ed Young, who's a writer for The Atlantic, who started following up with people. And I really think that if those patients hadn't been so outspoken about what they were seeing, because so many of them were also being dismissed within the medical facility or in the medical field, and that they were really trying to do this themselves. So it's now being far more recognized. NIH refers to it as the post-acute sequelae of SARS-CoV-2, or PASC, whereas CDC refers to it as the post-COVID conditions. I believe WHO is post-COVID condition, which is PCC. So they're all the same thing. It would be nice if they all named it the same. I know which branch I'm working on by whether or not I use it, if I call it PASC or PCC. But just like COVID itself, COVID has been such a strange, or SARS-CoV-2, right, has been such a strange virus in the sense that it affects literally head to toe, right? So we, early on in the pandemic, we had people who had brain fog and losing their hair, and then people who had COVID toes, right? You remember the COVID toes where people's toes turned blue. Well, just like the acute effects of COVID have impacted every single part of people's bodies, long-term effects of COVID are not much different. So we also see things like difficulties in concentration or thinking, or longer-term brain fog. Insomnia and depression have been associated with it. We see a lot of people who have long-term respiratory conditions, and then GI conditions and neurological conditions. So it really has affected all different kinds of things. And one of the very basic questions that we still have in clinical medicine is, what is the mechanism of this? So these are some of the driving hypotheses right now. And my suspicion is that we are I don't think that any one of these is the answer. I think it's probably a combination of those, or for one patient it's one thing, and for another patient it's another. And that would also help to explain why we see such varying differences, right? So you can have things like immune dysregulation. So it's really just that you never really cleared the virus. And so it's continuing to impact your immune system on this kind of lower level. And that's what's happening. We see that with viruses such as Epstein-Barr virus or other kind of herpes viruses that just kind of stay in your system. The next is that it could be related to microbiota dysbiosis. So dysbiosis in the gut is likely to cause all sorts of things, and not only the GI conditions, which is fairly straightforward, but also a lot of the mental conditions that we talked about, the brain fog, the anxiety, depression. There's long been a connection between the brain and the gut. And in the area that I work, we refer to them as disorders of the gut-brain, DGBI, so disorders of the gut-brain interaction. So we know that how the microbiota in your gut can affect your mental health state in a variety of ways. So it's possible that that is what's going on. We do know that there are the same receptors for SARS-CoV-2 in your gut as we see in the lungs, those ACE2 receptors. So next, it could just be that this is creating an autoimmune response. So it's not that you still have the virus, it's that you've essentially primed your immune system and now it's overreacting. We see that in a lot of other diseases. There are people who are reporting things like microclots, which have, if you're having microclotting in your blood system, that's obviously going to have a huge impact. And then others might just be, dysfunction of signaling or other kinds of things that are going on. And I think originally when people were starting to report having long symptoms, a lot of what was thought in the medical field is, well, this person was in the hospital for a month and they were on a ventilator, and so it's just taking them a long time to recover, which I think is very, very accurate, and that's true. But what we started then seeing is there were a lot of people who were reporting these conditions who didn't really have a severe acute infection. They never ended up in the hospital. They were never on a ventilator, and they were still starting to have these conditions. So there's more to it than simply, trying to come off of a ventilator. It takes a long time, or that somebody had such a intense infection that they had literal organ damage that it was causing this. So there's other things that are going on here. So some of the questions we have around long COVID is, some of them are very basic, right? Like, how many people actually suffer from long COVID, and to what degree? So for some people, it might just be that now things taste different. That's something that's, inconvenient, but certainly something you can live with. Other people who I have spoken to, their lives have completely changed. They went from being healthy and active to being having extreme fatigue to the point where they have difficulty getting out of bed or doing much more than moving through their house, and even that exhausts them. And so there's this wide range of outcomes for people, and it has now also been recognized as a disability, but we don't even know how many people are going to qualify for that. And that's not only a healthcare issue, that's an economic issue. So if we start having a lot of people in that realm, that's going to have big impact. So things like, what are the main symptoms? So I think over 200 symptoms have been associated with long COVID. But is there a couple of hallmark symptoms, for instance, that a person, quote unquote, has to have in order to be considered to have long COVID? Right now, nobody's really comfortable making that assertion because we do see so much variability, but it does make it challenging when you're trying to study a disease that has 200 symptoms and no diagnostic test. So we're continuing to work in that realm. We'd like to know what other factors are associated with long COVID. And then do less severe cases get long COVID at the same rate as more severe cases? It appears that's not the case. It looks like your severity of your acute illness has an impact. And I think the most important question for people is, how long does this last? So is this something you're going to have for the rest of your life? Is this something that if you get, you can tell a patient that they're likely to recover in the next year? Because it's for people whose lives have been changed, having some level of hope in that regard is really important, but we just really don't know the answers to that very well yet. So I'm going to go through some of the results of our studies and hopefully have still a little bit of time for people to have questions. So from an early analysis that we had really high numbers of people who were reporting long-term symptoms. So we had almost 70% of the people who were in our study were reporting symptoms more than 30 days. And those symptoms were fatigue, shortness of breath, brain fog, and stress. And the median number of symptoms was 3, with a range of 1 in 20. And we really did have people who had some of our participants had over 60 days where they were continuing to have this. But I think it's important to keep in mind that when we looked at this, this was a lot of the data from the early wave of the pandemic. Many of our participants had been infected with no vaccines on board, and so they were completely susceptible when they got infected, and it did actually seem to make a difference. And I think one of the things that when we first saw those numbers, we were frankly a little terrified with the results, because what we realized is that even if those numbers ended up being much higher than we expected. And right now, the estimates for long COVID are probably hovering around about 5%. So 5% of people who get infected end up developing long COVID. But a small percentage of a big number is still a big number, right? So if you have 100 million plus cases of COVID in the US, 5% of that is still, 5 million people with potentially debilitating conditions that they didn't have before this. So these are the things that we kind of continue to ask. So some of the things that we're looking at, like, does getting vaccinated help? It appears to. And that's not just our study, that's other studies as well. And I'll show you a trend that we're starting to see. Do other treatments like Paxlovid reduce incidence? There have been some early studies that have looked at that, and it also appears to reduce the incidence of long COVID, which makes sense, because if your Paxlovid is supposed to decrease your severity of symptoms, and if severity of symptoms is a risk factor for developing long COVID, it makes sense that both vaccination and treatment would reduce that incidence. But there are going to be some early clinical trials around Paxlovid to see if it actually is having that impact. And if anyone's had to take Paxlovid and knows the horrible, horrible taste in your mouth, I think they're going to have trouble getting people to sign up for being on Paxlovid for 2 to 3 weeks, but we'll see. So this is the trends that I was mentioning. So early on, as I said, we had the percentage of people that were developing it were clearly really high. And over time, those have continued to decrease. And we suspect that is largely due to vaccine and just people not being as susceptible as they were before. But we're going to continue to track this and see how those change over time. So I mentioned that one of the studies that I was going to talk about, and I have slides from some of the other ones if we have enough time or if you have follow-up questions. But I think one of the things that our group is particularly interested in is, what is the role of pre-existing conditions and long COVID? So people who already had things like diabetes or heart disease or respiratory conditions. are they at higher risk of developing long COVID after an infection or not? So within that analysis, we had over 1,200 participants who had had COVID that were included in this analysis. And 42% of those in that study had previously or currently or previously experienced long COVID. So either they reported that they were still having symptoms, or historically they had said they had had symptoms at a month or more longer, but had since recovered. So of those participants with long COVID, 1.47, there was times they were more likely to have a respiratory condition before getting infected and then developing long COVID. They were 1.62 times more likely to have a gastrointestinal condition, and 4.38 times more likely to have an autoimmune condition. And the autoimmune condition, again, isn't particularly surprising, given that one of the hypotheses is that long COVID is being kind of driven by this autoimmune reaction. So it could be that your immune system is already primed to have this autoimmune effect, and you get this infection, and now it's basically turning up that priming. But we have a lot of people in this country who have autoimmune conditions, and so knowing that those people are potentially at risk for this additional thing is important information to learn. So this just goes through a little bit of the more detailed results. One of the things that we also did that the lead author on the study, Dr. Beth Jacobs, did, which I thought was a really great idea, is that, as I mentioned, we were looking at, since we don't have a diagnosis, a clear diagnostic test for long COVID, we have to just look at symptoms. So for someone like gastrointestinal, okay, so let's say somebody had IBS beforehand, and then according to our data, they now have developed long COVID. Well, what we wanted to do, and is in that last column, is say, okay, well, let's take out any symptom that might be related to a gastrointestinal symptom. So we took out, we excluded any symptoms that would be gastrointestinal nature, and then reran the analysis to see if people were still at risk. And it does, in fact, I think it's the second column, not the third. And it does drop the association a little bit, but it's still there. You still see that same trend. And same with the autoimmune conditions, respiratory, but the magnitude of the effect is not as high, and it may not still be as statistically significant. So it is important that we're thinking through those things. On the flip side, though, we also have to take into consideration that for some people who have these pre-existing conditions, that having an infection with SARS-CoV-2 may make their pre-existing condition worse. So if you're somebody who, for instance, had IBS, but you were on medication and you had it fairly well under control, you got an infection with SARS-CoV-2, and now your symptoms are back, you're having flare-ups, everything's worse than it was before, that's also a significant outcome for you. And it's not a new symptom per se, but it's an exacerbated symptom of something you already had under control. So we're trying to really tease out what those are and have some additional studies looking at those. These were just some of the other ones. We also, seasonal allergies, which has come up in other studies too, and there's a lot we're still trying to unpack about what about seasonal allergies makes people more likely to develop long COVID. And like I said, I would have dismissed that if it was just us, maybe it was something weird in our population, but it's been reported in many other studies, so there's something going on there. And then depression and anxiety was the other one. So again, as I mentioned, our studies have been largely consistent with what other studies have found. We found that vaccination decreases the incidence of long COVID. Consistent with other studies, we have found that having a pre-existing chronic condition increases your risk, and those are the ones in our study. And then other risk factors look at increasing age, female gender, severity of acute illness, and pre-existing conditions are all risk factors that both our studies and other studies have found. So I'm not going to go, in the interest of time, I'll go through these fairly quickly, but we have seen that gastrointestinal symptoms were much higher during, for people who had GI symptoms during their infection. Their odds of having long-term GI symptoms was 4 times higher than people who did not have GI symptoms. And so that's something I think is important for clinicians to be aware of. So if you're somebody who had GI condition or GI symptoms as part of your acute COVID infection, what does that potentially put you at risk for longer term? And I'm going to go through these quickly. And then for the menstrual cycle study, we found that 16% of participants reported changes to their menstrual cycle after infection, both regular and infrequent periods, or increase in kind of premenstrual symptoms. And so they were also more likely to report a greater number of COVID symptoms, including fatigue, headache, body aches, pains, shortness of breath, and identify as being Hispanic. And this is important, one, because frankly, a lot of people don't look at women's health related to infection very often, but two, this does have an impact on reproduction and other kinds of areas, and frankly, just quality of life. So with that, I'm going to kind of just end for a plug for the study, which is that we are still recruiting. The website is there. People can link to it from there. The CDC surveillance study recruits as open to people who have recent infections that are 12 and over, and that is only surveys. And but the NIH study that I mentioned on GI, we are actually doing some biospecimens. We want to see how people's microbiome is changed by having infection and changed by having long-term chronic outcomes, as well as other specific immune markers. But the general cohort is open to anyone who's a resident of Arizona. So if you are a recent case, a never case, you got sick last year, it doesn't matter. We're available and open to anyone, and everyone can participate, 12 and older. So just a quick thank you to our funders. We also have I didn't mention, we have a study with grant with the ABRC, so the Arizona Biomedical Research Center with ADHS. And that we got a pilot grant to look at long COVID across the state, the National Institute of Health, and then the Center for Disease Control. And probably like many of you, we also did a lot of work on the acute side, and this is just some of the members of our team. We volunteered a lot in the pod that was the vaccine clinic that was on U of A's campus. So. Thank you. So with that, if there are any questions in the chat, I'm happy to answer them. We only have a couple minutes, but you're also welcome to email me directly if you have any questions about the study itself, if you are interested in collaborating in a way that we for recruitment or just anything else related to it. So with that, I'll turn it over to Mariah.
Awesome. Thank you so much. That was a phenomenal overview. We had one question that came in and you answered it towards the end, which is how can they get involved? How can they spread the word about participation in the study? So just thank you so much. And as a reminder to those watching, the slides will be posted with the recording. So if you have any additional questions that come up, or if there's anyone you'd like to share this presentation with, please spread the word. Thank you. Have a great day.
Thank you. Have a nice day.